Okay, welcome back everyone to part 2. So in this section, we're going to be talking about a few more specific considerations. So just as a refresher, my name's Roisin. I am the Equality, Diversity and Inclusion Specialist.
Hi, and I'm Sean Cropper, the Equality, Inclusion and Diversity Business Partner to Leicestershire and Rutland ICB. So in this particular session, we're going to be now looking at things like specific considerations around protected characteristics, health inequalities, a couple of case studies, and also looking at some of the resources that we've got for staff across the system.
All right, so in terms of the specific considerations, so in the first part, we talked more generally about the sorts of things you'd need to think about for every single project. But there might be some specifics which will vary depending on what you're doing. So we've got a long list here, and again, these are all covered in the templates and in the guidance. So when you're doing an equality impact assessment, it will talk you through step by step, and we hope it's quite user-friendly in that way. You won't need to kind of remember all of these. And at any stage, if you need to talk to your equality and diversity team, if you need to just get a second opinion on anything that you're doing, then that's absolutely fine. That's what we're here for. So the first section we wanted to talk about was about disability or different abilities. So accessibility is a huge one here. Of course, we want to think about the accessibility of our services for people with physical impairments, with sensory impairments. If people have got learning disabilities, you know, how are we making sure that language is easy to understand for people who've got those particular needs, people with mental health conditions as well, long-term health conditions. How are we going to make sure that we're accessible, basically? And neurodiversity also comes into this as well. Of course, not always considered to be a disability, but it's all about having different abilities. So it's still definitely very relevant here. It's about communication requirements as well. So if people need particular methods of communication, are we going to be adaptable to that? Are we taking into account that some people prefer to receive information by email or phone call? Letters might not be accessible for people with visual impairments, for instance, and we don't want them to be relying on family members to read them letters. Would much rather use email or phone calls if that's possible. Things like easy read as well, interpreters for sign language, all these sorts of things. We need to make sure, because these are kind of the fundamentals really, and we've got the Accessible Information Standard, which tells us about our duties with regards to making sure that information is accessible and understandable by everyone. So also with disability and different abilities, we need to think about impacts for staff as well. So if we're making changes to working practices, working hours, you know, have we got any staff with particular disabilities or anything like that, where that might cause a problem? So it's really important to not forget about the team as well when you're making service changes. Sexual orientation as well. So we want to make sure we're looking at all the different protected characteristics under the Equality Act, and sexual orientation is of course one of them. So part of this is to make sure that language is inclusive. We don't want to be making assumptions about people's relationships and things like that. We want to make sure that when we're using posters and leaflets and other materials and all sorts of things, that we're being inclusive with the language and we're kind of up to date in that way. And it also may be that there are some health inequalities to consider for certain communities. So we know that the LGBT community, for instance, they might experience certain health inequalities that other groups don't encounter. So we need to make sure that we are taking account of them if it's relevant to what we're doing. And similarly, gender reassignment, again, health inequalities is a huge, huge issue here. So we know that people who are trans or non-binary frequently report feeling like they are not as confident accessing healthcare, which is a real issue. So we need to make sure that we are, again, using inclusive language, welcoming people into our services. And ask yourself, you know, is it important to know the sex registered at birth for your patients? Or is it actually not relevant? So we only want to ask information when it's necessary. We have race and ethnicity as well. So very often we'll get queries about this, and I think the kind of the obvious one is about languages and translated materials. So of course, if someone's preferred language is not English, then we need to be providing them with an interpreter, we need to be providing them with translated materials. But actually thinking about race and ethnicity goes well beyond that as well. So have you considered again what relevant health inequalities there might be for certain ethnic groups? We know that there are some services where people are really underrepresented, so perhaps they don't get referred into our services as frequently as other ethnic groups, or maybe they get referred in more. So do we understand the reasons behind that? Is there any supporting evidence as well? And race and ethnicity is really important. It can be such a fundamental part of someone's identity. We want to make sure that we are being respectful of people's cultural norms. You know, if we're going into someone's home, then there's a lot of considerations there. If we're talking about kind of inpatients, then it might be that someone's got certain dietary requirements or anything really. We just need to really make sure that we are, again, being responsive to people's individual needs. And if you feel like you don't really know where to start with race and ethnicity and what considerations you need to be thinking about, then this is again where that inclusive engagement really comes into it. So using community links, using like voluntary groups and things like that, as well as, you know, members of staff and patients who are happy to give their thoughts on what might be really important to certain communities. And it's important to also consider white minority ethnic groups, such as people from Eastern Europe, Gypsy and traveller communities as well. So there's a lot to this one. There's a lot of potential impacts that you need to think about. And when we talk about religion and belief, again, it's thinking about people's needs in terms of prayer facilities, timings of appointments and things like that. So you're not kind of interfering with holy days or religious festivals, things like that. Again, dietary requirements, requirements for kind of like religious sensitivities as well, particularly caring for palliative patients. There might be certain cultural requirements at that stage of people's life and specific health beliefs. So again, you can reach out to local religious communities, and we've got links into those communities. You don't necessarily need to kind of reinvent the wheel there. You can just contact your EDI team or contact your patient experience team, and they'll be able to put you in touch with some relevant people who could be able to help you.
Okay, so I'm going to be looking at, first of all, pregnancy and maternity. So again, we've got to be looking at accessibility requirements for people who are pregnant or have just had a child or need to feed their baby or express their milk in private. Also, not forgetting that there is a right for people to express their milk in public as well under the Equality Act. So also need to be looking at, when people are pregnant, the kind of different medical and social requirements that people might need, and also that is there a care, treatment or medication suitable for pregnant and breastfeeding people as well when we're looking at actual remedies. Carers. When we're looking at carers, we need to be looking at remembering that we have people that care for children and also people that care for family members, friends or neighbours. So it's both. We're looking at mainly informal carers here. We're not looking at professional carers. And carers are often linked with the person that they are caring for. And so if a carer is caring for a disabled person, for example, they are often linked by the fact that they under the association factors of discrimination. So because they're associated to somebody who has a disability, you can sometimes find that carers are protected that way as well under the Equality Act. So for example, if you're discriminating against a carer who's taking time off to look after a disabled person, they might have a legitimate reason to do that. So social economic status. So this is one of the things that is obviously, especially under the health inequalities agenda now, is really, really important. And what we're looking at here is that how people's background, social economic status can affect them. So it's people like on low incomes, people who have experienced or are experiencing homelessness, people that are living in deprivation at the moment. So these are really, really important factors which will have a detrimental effect on people's health outcomes. So also, we're just going kind of summing up some of the other disadvantaged groups here. So when you go on to the actual quality impact assessment template, there are lots of different disadvantaged groups which are listed, which people can go into and look at them in terms of what you think the effect will be. So I think one of the big things at the moment is around internet access, and a lot of people still haven't got internet access, and an example would be that following the financial crisis that we've been having, a lot of people have actually given up their actual internet providers because they can't afford to actually have internet access anymore. And there's still people that still don't always have the technology. So having an internet solution is not always the only solution. We do have to look at other things as well. We also need to remember that people, a lot of people across the community still only have basic reading or writing skills. So when you're actually pitching your information, you need to really be thinking about taking that into account, making making the actual wording itself quite simple and in plain English. We also need to consider those people that don't read English as their first language. And of course, we have this is about reading English as a first language. So we need to be looking at other ways of providing that service. So also the disadvantaged groups, we consider migrant groups. We look at Gypsy, Roma and traveller community, which tend to have very poor health outcomes. We look at people living in rural locations. People that also have addiction and substance misuse, people who are ex-offenders, sex workers, and are in care or have previously been in care. So this is people that are called looked after a lot of the time. So these people often have a lot of bad experiences throughout their life going through the system, and also this can have a detrimental effect, especially when they come to the point of becoming an adult, and what services are there at 18 years of age to support these people. Okay, so health inequalities. So health inequalities, we've actually incorporated something called the HEAT tool, which is the health assessment tool. We've incorporated that within our new quality impact assessment template, and we did that because we wanted to have everything in one place. So basically, we are including health inequalities within the template in various places. So what are health inequalities driven by? Well, they're often driven by things like structural factors, the environment that people live in, the community, the income or housing that people live in. Also, an exposure to social, economic, environmental stressors. So stress and psychological well-being can affect people's resilience. It could affect their health. It could affect their behaviours. We also know that differences in health behaviours are often risk factors. So, for example, different risk factors around smoking, diet and physical activity levels. Now, it's often influenced by determinants of health like income. So the income can affect some of these actual health behaviours. And finally, and linking back to one of the first slides that we looked at, and also under the Health and Social Care Act, we need to be looking at the unequal access or experience to health and other services. So the experience and access and outcome. A lot of people that come from these particular groups have unequal access to them. So something that we've been working on within LLR now, and it's a national thing, is produced by NHS, is something called the Core 20+5. So again, this is within the templates and the guidance. And what this is actually designed to do is to help integrated care systems to drive targeted action towards healthcare inequalities improvement. So the basic premises of this is that the core 20 is that within our system, we must include and look at the most 20 deprived of the population as defined by the index of multiple deprivation. The plus is the fact that we must be looking at population groups experiencing poorer than average health to access, experience and/or outcomes. So this is defined locally, and this would involve within LLR, such as the BME community, people with learning disabilities and autism, the Gypsy Travel Roma community, military and ex-military, particularly in the Rutland area, farmers, rural communities. So they're some of the people that within LLR we've defined as plus groups. And then nationally, we've also been asked to look at these five areas where we must look at to help improve. They are maternity, which is around ensuring continuity of care for Black, Asian and minority ethnic communities from the deprived communities. Severe mental illness, ensuring that annual health checks for 60% of those living with severe mental illness are in line with success seen with learning disabilities. That we push up the things like COVID and flu vaccinations to reduce the need for emergency care around chronic respiratory disease. We're also looking at early cancer diagnosis. Now, I'm not too sure if that may have changed due to the recent government headlines in the last 2 weeks while I'm doing this actual piece of training, but it used to be 75% of cases diagnosed at stage 1 by 2028. And also to look at the hypertension case funding, which is optimal management and lipid optimal management of those. And one thing that cuts across all of that is smoking cessation or stopping smoking. More recently brought in across the system as I deliver this templates is the one for reducing health inequalities for children and young people. So again, we still have the same 20% of people deprived in the index of multiple deprivation. We still have those plus groups, those people from the Gypsy Traveller communities, people learning disability and autism, etc. But the actual difference areas here for children are around asthma, diabetes, epilepsy, oral health and mental health. Okay, so when we're looking at specific considerations, and one thing that is part of the public sector equality duty is to look at good relations. Are we fostering those good relations? So whenever we're bringing in a policy, practice or procedure which affects our community, are we taking that into consideration and trying to, create, not trying to create any risk of creating tensions within community groups? So just to make sure that when we're doing our comms, etc., we're explaining why certain things are being done in a certain way.
So we're going to move on to talk about a couple of case studies now, just to give you some examples of where the IDMF, the Inclusive Decision Making Framework, has worked quite well. So these are both quite big projects, not necessarily going to be similar sort of size to the projects that you'll be working on, although they might be, but just to kind of show you that for any size project, the IDMF can be a really good starting point. So the first one is about the UHL reconfiguration. So this was where University Hospitals of Leicester moved some services from the General Hospital and the Glenfield to new sites. So moving services between hospitals as part of that reconfiguration project. So it required really careful equality analysis right from the very beginning. It wasn't obviously just the services moving, it was also had a big impact on the staff, had a big impact on patients because they were moving to their new homes. So we asked the project team how the IDMF was applied to decision making. So there was a full review of the reconfiguration programme with EDI leads. That was really important that that was done right at the early stage, all the way through to completion as well. So that's what we were talking about in the first section, was the importance of regular monitoring and keep updating that equality impact assessment so you know that you are working with the most up-to-date information that you could possibly have. They also did quite wide-ranging training on the IDMF, so all the project managers involved in this work were trained on what the IDMF is all about, in how to use it practically, and also in the kind of the theory behind it, so why it's important to think about inclusive decision making. And they really moved away from generic equality statements and more into specific equality impact statements. So when they were reviewing their documentation, they made sure that they were really getting to the crux of what the equality impacts were, and they weren't just kind of making these general vague statements. So they had some top tips. The first one being go to the people. So really important to engage with people for something like this, which is going to impact a lot of people. Make it interesting and fun if you possibly can. So the more kind of interactive you can make that engagement, the better. Continually review. So as we've said, really important to do that. Otherwise you might miss what your data is telling you. Understand that one person cannot know everything. Inclusive decision making really means sharing ideas between all relevant stakeholders and getting people's different viewpoints. And cross-team working enabled shared problem solving. So it's really important to involve people from all the relevant teams, all the relevant professions, to make sure that they assessed all the equality impacts.
Okay, so case study 2 is the LLR COVID vaccinations. Now, I'm actually reading this kind of on behalf of the actual people that actually presented this a while back. And these were the people that were piloted the programme and came and gave a showcase in December 2021. However, I have actually been involved in the COVID vaccination impact assessments during this time. Okay, so what they found out was, so when they look at how was it actually applied to decision making, how was the IDMF applied to decision making? Again, they use an evidence-based approach, which is the whole point of the inclusive decision making process, to get rid of any kind of bias, to base it on evidence. The impact assessment was thorough, like not a tick box exercise, as we were saying at the beginning under the Brown principles. They identified the priority groups at the time for the vaccination programme. They had regular performance monitoring meetings, and they utilised local, regional and national forums and networks to actually get their data and feedback. And their top tips were that you needed to get senior buy-in across the system early on, that you have clear aims and objectives, very important, especially when that's right at the beginning of your step 1 of an EIA. To ensure that diverse membership of the actual team as well, making the decision, that evaluation is built in from the start, which is really important, again, which Roisin's mentioned when we looked at the steps, that we consider health inequalities, and as we said, we've got more in our template now around that, and the HEAT tool, and that we have a very strong evidence base. You can't make decisions without evidence, really, whether that's data and consultation. You know, you need that to actually make your decision.
Okay, so we just wanted to finish up by sharing a few other resources which can help you. So hopefully throughout these couple of sessions, you've got a bit of better understanding about the equality impact process and how inclusive decision making is really important throughout that. Hopefully as well, you'll refer back to the templates and you'll see that it doesn't need to be this kind of onerous process. It can actually be a really great way to incorporate engagement into a really early stage of your project management. So we hope that the resources that we've made available to people are going to be helpful. But again, if you have any questions at all, please do contact us. So that's the first port of call, really, is to talk to the EDI team for your own individual organisation. Also across LLR, we have cultural competency enablers. So these are people who've been trained up to be role models and champions for cultural competency. So they would definitely be available to give their advice and support if you've got any particular questions about cultural awareness, about kind of influencing change, that sort of thing, then they are definitely a good resource. So if you want to get in touch with them, again, contact your EDI team. Or we also have some health equity champions. So again, this is a champion role for anything to do with health inequalities and equity. So if that's something which is important to your project as well, then definitely tap into that resource. Across LLR, we're really proud of the EDI programs that we've got available. So we've got our reverse mentoring. So this is all about mentoring more senior colleagues to develop their cultural competency around particular protected characteristics. It also gives more junior colleagues valuable experiences for networking, a bit of coaching and development as well. We've also got specific development programs like the Developing Diverse Leadership scheme as well. So it's all about inclusive talent management and succession planning. And we've got national programs for developing diverse leadership as well as our system level ones. We have our active bystander program. This is all about making sure that people feel empowered to be an active bystander, to stand up for colleagues who are perhaps experiencing bullying, harassment or abuse, making sure that there's always someone who's going to look out for those situations. And also our equality delivery system. So our EDS 22 is the way that we make sure that we're monitoring our organisational priorities and that we're moving in the right direction in terms of EDI. So that's it for this session. We do hope that you review the templates, review the guidance, see what you think. And again, if you have any questions, just get in touch and we're very happy to help.
Thank you.